using this. Okay, you'll have the one. Yep. Good. I got
For those of you who are standing near the doors, and there are people on the outside who look like they are attendees, will you inform them that we are about to begin? This is our grand finale, and as tradition has and holds, due to the gracious consent of our final speaker, it is tradition for Tony Komaroff, Dr. Anthony Komaroff, to provide a wrap-up summary, which is in my opinion anyway, certainly the best part of the meeting, because with all his experience in dealing with chronic fatigue syndrome in both clinical and research practice, his mind is like a steel trap and nothing escapes it. It also has the ability to filter chaff from wheat, and therefore he has the uncanny ability, the unique ability, to be able to distill down to its essence what is important and significant in content at these meetings. And once again, he has kindly agreed to offer his view of the distillate of this meeting. And we are very grateful for his willingness and his ability to do this. And so I will thank him publicly for doing so, and without further ado, ask him to begin offering his wisdom to us. Tony?
Thank you very much, Ken. And I will try to distill down to some simple slides the data and the conclusions from the data that during this meeting impressed me the most. This is one person's view of the highlights of the meeting. Inevitably, there will be very good work that I don't mention. I really tried to find themes that spanned one presentation to the next, and that influenced heavily my choice of highlights. The questions, I'd begin by saying the questions addressed by many of the presentations, even though the work they were doing was entirely different, the general questions addressed were, in an illness that is defined exclusively by the subjective group of symptoms, is there evidence of objective underlying biological abnormalities? Question one. Second question, could those biological abnormalities theoretically explain the symptoms? And then finally, do the abnormalities in fact correlate with the symptoms? We'll come back to those themes repeatedly. One of the highlights of the meeting to me was not the result of any particular study, but the evidence that we now have a group of different huge chronic fatigue syndrome databases and biosample banks. There is the long-standing work by Dr. Klimas and Fletcher, now at Nova Southeastern University and the University of Miami and the Miami VA. A huge database of clinical information, biosamples. You have today, at this meeting for the first time, the presentation of the new, very large effort at Stanford Medical School down the road to build a database of clinical information and laboratory samples. We heard about the results of the Chronic Fatigue Initiative, a charitably funded enterprise that created a large multi-center databank and biobank. We didn't hear about, but there also exists as the result of a large NIH multi-center trial that was headquartered at Columbia by Drs. Lipkin and Hornig, another multi-center database with clinical information and biosamples. And then finally, we heard about the UK MECFS biobank that is being developed. Immunology, that was the first theme in the program on Friday. And the highlights of that to me were the CFI study, Chronic Fatigue Initiative study, which found elevated levels of allergy-associated cytokines and chemokines, I've highlighted them there, and other pro-inflammatory cytokines and chemokines in patients who had been ill for less than 3 years in comparison to those who'd been ill for greater than 3 years. It validated a sense by this study and its design that most of the biological action that you're going to be able to detect is more likely to be there in the earlier stages of the illness than the later stages. The second point, coming from the Stanford studies, was the ability of multiple inflammation-associated molecules, not all cytokines, but even fat cell-produced hormones, adipokines, to separate CFS cases from healthy controls. Specifically, the Stanford studies that we heard about on the first day included nearly 200 CFS patients compared with nearly 400 age and sex-matched controls, on each of whom levels of 51 different inflammation-associated molecules, cytokine family, chemokines, and hormones, were measured. To my knowledge, with the possible exception of the CFI study, a study of that size, that number of patients, simultaneously assessing that many different molecules is unparalleled, not only in the CFS field, but in many fields. 15 of the 51 molecules that they focused on either distinguished cases from controls or correlated with symptom severity, or both. Here's a sample from one of Dr. Montoya's slides. Can't see it very well, but this is a group of, I think, 14 or 15 different cytokines that plots severity of symptoms against the level of the cytokine. And I think you can see that for most all of these cytokines, as the symptoms became more severe, the level of the molecule was higher. A linear correlation between the molecule and the symptom. Doesn't mean that the molecule is causing the symptom, but it could mean that. Another way, and this also doesn't project well, Jared Younger and Dr. Montoya's center did a study that tried to look for associations between the various cytokines measured, and the startling result, at least to me, was the primacy of leptin. Leptin is a hormone discovered about 1994 that is made by fat cells and that diminishes appetite and has a powerful role in weight regulation and appetite control in humans and animals. That molecule should be so closely tied to immune system molecules, cytokines, was striking, and that it should so predominantly correlate with the levels of fatigue in the CFS patients was a novel insight, the meaning of which I'm sure many groups will be pursuing. So I just mentioned these elevated levels of leptin in CFS patients, and I didn't mention, but it is true, we saw the data, that those leptin levels were correlated with the severity of the symptoms, particularly the fatigue. Another highlight of the Stanford study, also found by the CFI study that Dr. Hornig reported, is elevated levels of interleukin-17. This is the prime mover of the so-called Th17 immune cell that has been very strongly linked to many human autoimmune diseases, or more precisely, an elevated level of IL-17 or the Th17 cell compared with what are called T regulatory cells makes the risk of an autoimmune disease, of many autoimmune diseases, worse. And it suggests that autoimmunity may be playing a role in CFS. Significant decreases were reported in several microRNAs that control the production of pro-inflammatory cytokines. That is, the decrease in the microRNA would tend to increase the production of pro-inflammatory cytokines, which is what was found by the studies. So it's internal biological confirmation of what you would expect to see if these findings are really valid. And then finally, there were, to me, striking results about one particular cytokine, interferon gamma. I want to take a brief side tour into a statistical term, odds ratios, for those who are not familiar with it. An odds ratio compares the frequency of a finding, any finding, in one group, like people with CFS, versus the frequency of that finding in a comparison group, like healthy controls. The odds ratio is reported as a number, and then with the confidence interval associated with that number. The lower limit it could be and the upper limit it could be. 95% confidence interval. If you have an odds ratio of 1.0, it means there's no difference in frequency between the two groups that you're comparing. If the confidence interval spans 1.0, it means the difference is not statistically significant. Most of the odds ratios that you see reported in the literature on most conditions, and most of the odds ratios you saw at this meeting, fall into the range of between 1 and 5. It's not very common to see odds ratios in large studies that go above 5. It means a 5-fold greater chance of some finding in one group compared with the other. So that's by way of background. What did we have presented to us buried in a set of very complex tables in one paper and found in a poster presentation of another paper? We had two striking odds ratios from Dr. Hornig's group on interferon gamma. In the CFI study, Chronic Fatigue Initiative study, 200 cases compared those who were ill for less than 3 years with those who were ill greater than 3 years. The odds ratio of interferon gamma was 117, with the upper confidence interval being 1,072. I've never seen an odds ratio like that. I've never seen an association that so strongly discriminates one group from another. And then that same molecule, interferon gamma, was found to correlate with cognitive impairment, comparing a highly impaired, cognitively impaired subgroup to a low impairment subgroup with an odds ratio of 67. So this is a striking statement to me about this molecule and its possible role in this illness. Interferon gamma is thought to be commonly released by viral infection or infection with intracellular bacteria. So it suggests, but by no means proves, that in CFS there may be an underlying infectious agent. We heard another interesting finding that's sort of basic biology. It doesn't fall into any of the categories at the meeting, about telomeres. I think many of you know, but a quick overview, telomeres are the ends of the chromosomes where they all come together to be tethered together at the opposite ends of the chromosomes. Over the last 30 years, it's become clear that those telomeres are not just structural elements, that their length affects the viability of the cell. The shorter, with every cell division, the telomere shrinks a little bit. And so therefore, short telomeres mean this is a cell that has divided many times and is relatively older. When telomeres get to be short enough, all of a sudden the cell dies. So short telomeres are a marker for cellular aging, and short telomeres are increasingly being shown to predict an increased vulnerability to a variety of diseases of aging, including atherosclerosis, neurodegenerative diseases, several malignancies. One demonstrated association with shorter telomeres is perceived life stress. That work was done here in San Francisco at UCSF by Elizabeth Blackburn, who won the Nobel Prize 4 years ago for her work on telomeres. She showed that when people are under stress, the group she first studied were parents caring for sick kids. The parents who were under the most severe stress and perceived this as a major stressor were likely to have shorter telomeres. So Dr. Rajivan from CDC showed us good data that telomeres are shorter in patients with CFS. By no means a finding unique to CFS, but it's a finding that suggests that there is an underlying biological process that is making patients with CFS age a little faster. Virology and infectious agents was the next general section of the meeting. The Chronic Fatigue Initiative study reported the results of a really intensive molecular screen for infectious agents. And the first report was of agents in serum. And they found basically no evidence of microorganisms present in serum. The questions to be addressed in the future are, what about in circulating white blood cells, the cells themselves, not the serum around them? And what about in other organs and compartments, particularly the brain and the gut, the microbiome? And those are studies for a future time, several of which are underway. Dr. Chia reported again at this meeting, as he has in the past, the expansion, the latest summary of data from a remarkable report and a remarkable amount of work. Enterovirus, antigen and nucleic acid found in biopsy samples from stomach in cases and control subjects, finding very marked differences in the frequency of both antigen and nucleic acid in CFS patients compared with the controls. He then also reported that when you took the biopsy specimens that these tests suggested contained enterovirus and injected them into mice, that in fact you found, when you sacrificed the mice, evidence of enteroviral infection, a virus, in the mouse, indicating that this thing that lit up looking like it might be an infectious agent on the biopsy tissue actually produced an infection in another animal. To me, these results are very impressive, but it's also depressing to see that, to my knowledge, no academic enterovirologists have sought to try to reproduce this, not even in bulk, to take the samples that already have been collected at an enormous effort by Dr. Chia and test them themselves to see if they get the same results that Dr. Chia does. It's a great shame, and I hope it changes. Public health epidemiology, the Canadian Community Health Survey, was massaged to try to come to an estimate of the number of Canadians that have CFS, and estimated about 1%. That's about 2 to 4 or 5 times higher than in the United States, it may be just that because these data come from survey and patients weren't then subjected to physical exam and deeper interrogation to see if they might have other conditions that cause fatigue, it would have been a lower number. The CFI epidemiology study surveyed nearly 1,000 patients who had been from multiple centers and ascertained that about a third had experienced at least one remission during what typically was a 15-year history of illness, and that the remissions had lasted on average about a year, but in most people, unfortunately, had not persisted. It's the latest study of prognosis in this illness from a long-term database. The CFI EPI study also reported that rest, exercise, and diet were the interventions that most CFS patients have found helpful in comparison to standard pharmacologic therapy or alternative and complementary treatments. The CFI study finally reported that CFS patients were much more likely to report many comorbid illnesses than were control subjects. Actually, they didn't report that comparison to controlled subjects, but it's true from the CFI data. Case definition. Lenny Jason magnificently led a discussion of what you want in the case definition and was, I think, critical, and fairly critical in my view, of the current case definitions that are out there. The points he made as I took them were that case definitions, if they're really going to do the job you want them to do, need to be precise. You don't want to just list a group of symptoms or physical exam findings. You want to tell the person who might use that case definition, well, how do you actually define that symptom? When is the severity of that symptom high enough that you want to check the box? That kind of thing needs to be done more. Several groups have attempted it, but it's honored in the breach in CFS research. Empirically derived case definitions, he argued, are superior to consensus-derived case definitions, such as most of them that exist today are, because they become better at defining subgroups. If you just collect a lot of data very rigorously and use statistical techniques to look for subgroups, don't impose your biases on it. Just, do the data tell you anything? Are the data talking to you? Do they tell you, whoa, this symptom and this symptom correlate together very tightly in most patients? That has been done and needs to be done more in defining subgroups, because I think most of us believe CFS is, if not a group of different but similar diseases, is a disease with a bunch of subgroups that may, in fact, respond to different treatments. And finally, empirically derived case definitions are going to prove to be better at what we want a case definition to do, which is to predict some endpoint, like a prognosis or a laboratory finding that's thought to define the pathology of the illness. The next session, called the provocation session, was really a session about exercise studies. And the main concept behind these studies was that if a stressor, if patients tell you that a particular stressor makes them feel worse, then the time to study them, to see if you can identify the underlying biology of the illness, is at a time when they've been subjected to that stressor and are likely feeling worse. And in fact, a double dose of that stressor should bring out the underlying pathology even more. And so what we heard from several groups was that although on a single exercise study, CFS patients did not consistently perform below the levels of healthy controls, of which there are abundant normative data, when those patients were exercised 24 hours later again, you saw all sorts of abnormalities popping out. And you did not see that, not only in healthy control subjects, but you do not see, we were told, that degradation in performance on the second test in people with heart disease and lung disease, who are the main people who get this kind of exercise study. So it doesn't say that this degradation on the second day is unique to CFS, but it says that in their experience, long experience as exercise physiologists, they haven't seen it before. And that's probably telling us something about this illness. And then finally, we heard a report that low peak oxygen extraction relative to an increase in cardiac output occurs in some patients, implying a metabolic defect, possibly a downregulation of carbohydrate metabolism. Pediatric CFS, the findings that stood out for me were that there was a surprisingly high prevalence of delayed milk protein sensitivity in kids with CFS that often was unrecognized and that was causing symptoms that sometimes were attributed to CFS. And that by identifying it and changing dietary patterns, you might be able to relieve some of the suffering of kids with CFS. Second paper talked about a combination of widely available, inexpensive laboratory tests that appeared to predict which young adults and teenagers with mono would go on to post-mono CFS. To me, that's interesting. We know for 15 years of research that there is a post-mono CFS, and several fancy laboratory studies, sophisticated immune studies that are done only in certain laboratories, seem to predict who's going to go on to get post-mono CFS. But those studies can't really be done reliably in most practices. The studies that were the types of laboratory tests that were reported here are available to every laboratory, very inexpensive, and this may prove to be a useful finding in kids with mono and intervening in some way to prevent post-mono CFS. And then finally, the last report in the pediatric session that I thought made it an important point was that when they surveyed kids with CFS for depression, they found evidence of a concurrent depression in only about 25% of the kids, even in the months and years after they became ill with CFS. In teenagers particularly, I believe the background prevalence, point prevalence of depression is around 15 to 20%. So this is marginally higher, as you might expect when you're suddenly hobbled with a debilitating illness, but it is only in a minority of the patients. Brain research. We heard from the Zins at Stanford about quantified EEG studies, brainwave studies, that demonstrated a remarkable ability to distinguish CFS patients from healthy control subjects. And I'll cite that data in a minute. And we heard from the groups in Osaka and Kobe, Japan, studies of an activation of key brain immune cells, microglia and astrocytes, using PET scanning that say something about the underlying biology of the illness. The QEEG studies we heard about this morning at Stanford involve 50 CFS patients, 50 matched controls. And there were three findings that stood out. One was that alpha wave, peak alpha wave frequency was significantly reduced over most of the cerebral cortex in patients with CFS. Delta wave frequency was increased, and I didn't say it here, but beta wave activity was also reduced. This was particularly true in the frontal lobes and the limbic areas of the brain, and both abnormalities not only were present and clearly distinguished CFS patients from healthy controls, but the degree of the electroencephalographic abnormality correlated linearly with the degree of the symptom, whether it was fatigue or pain. These brainwave abnormalities were thought by the ZINs to indicate likely disruptions of information transfer across cortical networks and inhibition of ascending arousal systems. They are the sorts of things that you see in a whole host of well-documented neurologic diseases, and you don't see in healthy people. The PET scans that have been done by the Japanese groups in the past have demonstrated reduced cortical blood flow, reduced glutamate, an important neurotransmitter, reduced serotonin transporter, and increased dopamine biosynthesis. At this meeting, they used PET scanning for a new purpose. There is, and you've heard it repeatedly in the last 3 days, a theory that CFS, at least in some people, might reflect an ongoing activation of immune cells in the brain, not in the periphery only, but in the brain. And that if you could find evidence of a chronic immune activation state in the brain, then all of the cytokines that are elaborated as part of that chronic immune activation could easily explain many of the symptoms of CFS. But how do you measure immune system activation inside the intact brain of a human being without some invasive approach? Their imaging technology included a ligand for a particular protein that is thought to be specific to the activation of the immune system cells, the microglial cells and astrocytes. And it showed that in a small study, 9 patients, 10 controls, there clearly was increased signal, evidence of immune activation in these cells in multiple areas of the brain, not in all areas, but many areas. Areas that incidentally have also been found to be abnormal in many other kinds of imaging studies. The intensity of the signal correlated with cognitive impairment. Again, not just finding an abnormality, but demonstrating that it correlated in degree with the degree of important symptoms. So, in summary, as I said at the beginning, many of the presentations today ask the question, in an illness that's defined entirely by subjective symptoms, is there evidence of underlying biological abnormalities? I think the evidence clearly is yes. Could those biological abnormalities theoretically explain the symptoms? You've heard multiple investigators say, yes, absolutely they could, from what we know about those abnormalities in other conditions and diseases. And then finally, do the abnormalities that theoretically could correlate with the symptoms actually correlate with the symptoms in patients who are reporting their symptoms at the time they're being imaged or studied? And the answer was, repeatedly, yes. So I would conclude that the last 3 days and the science that's been reported over the last 20 years shows repeatedly that when patients with CFS are compared to various comparison groups, healthy subjects and in many cases other fatiguing diseases, what you find is robust evidence for an underlying biological process that involves the brain, autonomic nervous system, immune system, energy metabolism, and although we didn't hear a lot about it at this meeting, oxidative and nitrosative stress. In summary, the illness is not simply the expression of somatic symptoms by people with a primary psychological disorder. It was a fair question 30 years ago to ask whether people with these symptoms might not just be expressing psychiatric stress, amplifying normal body sensations, or even fabricating for secondary gain. Was a fair question 30 years ago. But today, it's no longer a fair question. Thank you very much.
Thank you very much, Tony. Again, you have hit the highlights, and I hope if there were any confusion for particular aspects of this conference, for those who do not have expertise in those areas, you have made it clear. And you have certainly sent a message, the primary message, that science will reveal the nature of this illness. If you have comments or questions that you wish to have Tony address at this point, I guess we can forego the rules and just raise your hands or come up and take a microphone here.
Do we have a portable mic over there?
Do we have a portable microphone? I'll be the runner.
Okay. Terrific.
So Tony.
So Nancy.
Do you think we're at the point where we can use biologic markers for this disease clinically?
Well, I don't think we have evidence yet that any of these biologic markers is sufficiently sensitive or specific to constitute a diagnostic test. Several are close, and one of those EEG figures showed nearly a perfect separation, if I remember, between cases and controls. So maybe that day is coming, but I'm not sure that we have yet something we can call a diagnostic test.
How about clinically to monitor to pick a drug?
Oh.
Nancy.
Sorry? Let's say it again into the microphone.
Would you, rather, I wasn't really saying for diagnostics, but rather for managing and following and therapeutic decision making, would you be, I know what I order.
Sure.
Are you going to up the ante and start ordering anything else?
I think several, for example, the finding that dopamine production is downregulated, I believe, could lead to a trial, but it would have to be a randomized trial of interventions that ramp up dopamine production. I mean, I think where you find a result that has a therapeutic implication, that ought to be tested in a randomized trial. I'm less comfortable with saying the individual clinician who has available a dopaminergic agent should use it in an uncontrolled setting to treat patients. But I would hope it would lead to controlled studies.
Given the fact that the Japanese group found neuroinflammation in the hippocampus and the thalamus and the pons, which is anatomically part of the spinal cord, neuroinflammation, not classic inflammation, but it's still inflammation. Isn't that encephalomyelitis?
Yes. If it were confirmed by multiple other investigators, it would, for me, say there is a low-grade chronic encephalitis in these patients, that the image we as clinicians have of encephalitis as an acute and often dramatic clinical presentation that can even be fatal may have blinded us to the possibility that there may be an entity of long-lasting, many years long, cyclic, chronic neuroinflammation, and that is underlying the symptoms of this illness. Entirely plausible. These data are consistent with it. But I would feel more strongly if other labs using the same technology came to the same result.
This question may be more for Dr. Klimas here. In terms of the cytokine changes that we're seeing consistently over various labs all over the world, as well as the NK cell function, how can we use biologics? And in terms of the study, the very small study in Norway with rituximab, how does that kind of make sense with that clinical finding improvement in certain patients?
So since she asked me.
I'd rather you answered, Nancy.
So I think that first NK cell is very powerful. I think we have all the evidence we need to be calling that a biomarker of this illness and need not continue hammering down on that. It just, since Tony's first paper in 1987,
I thought it was in the Jurassic era.
Our paper in 89, Levy's paper in 89, and every other paper since, you know?
So it's a biomarker, but you have to use it with caution as a diagnostic.
So Cindy says, we don't know what sensitivity and specificity. I would say, though, that we do have a number of papers to show that it tracks with severity. Okay? So anyway, what I was trying to say is, well, these immune-based biomarkers, I think, are reasonable places to define subgroups. And particularly as we move towards therapeutics that are very specific. For instance, if you're going to use, I'm going to skip the Norway question for just a second and say, I'm going to use a TNF biologic response modifier. Pick the people with elevated TNF. We have reliable ways to measure that. And we have reliable ways to, with the receptor measures, to confirm our observation that TNF is elevated. Do it a couple of times and be certain we got the right group, and then, yeah, that's a targeted subgroup study. We do placebo-controlled studies that way. We're much more likely to have the level of efficacy that catches everyone's attention and says, oh my gosh, yes, this is right for this subgroup. In K-cell dysfunction, if there's a treatment that's aiming at enhancing K-cell function, of course you pick people low in K-cell function. So I think we have biomarkers for subgrouping, and I think that Dr. Fletcher actually would concur and presented some of that, and we presented some of that in our session. I'm going to pass the microphone back and go into Tony's question.
Yes, hi. I'm an advocate, so it's kind of an advocacy question. Thank you, Dr. Komaroff, for your summary. It was great. Coming to these conferences year after year, it's so promising, and we always end on the same note that there's so many biological abnormalities, and yet we can't seem to declare that we have biomarkers. And my question is, it's sort of a chicken and the egg question. Until we accept a universal case definition for this disease, that may always be the case. We might not have as many subgroups for this disease as we think, because we're not replicating science, and we'll never find targeted drugs until we all admit that we need to adopt a single case definition. For example, the Canadian consensus criteria would be a good start. So I would like you to address that, and also to address the fact that you're so wonderful in all your summaries of biological abnormalities on the CDC website here and everything else. And advocates were astonished 2 days ago with your interview that appeared in the Monterey Herald that talked about wonderful things about the biological abnormalities, but it ended with saying CBT and GET are really, good treatments. So if you could address both of those. Thank you.
Wonder if I could just respond to the "you are so wonderful" part. I don't want to get dragged into a discussion of the role of CBT because I know it's a polarized issue. It wasn't discussed at this conference, and I don't want to. I'll be happy to talk with you individually about it. In terms of whether all investigators should use a common case definition, yes, that would be the ideal. And I think the problem is that not all investigators agree on what's the best and easiest to implement case definition. And part of the problem with choosing any one is that if there's a lot of literature already that uses another case definition besides the one that you regard as currently best, that it'll be hard to compare the results of any studies going forward with the published research that already exists. So I don't think there's a good answer to that question. And if there is, I don't have it. Yes?
That was an excellent summary, and I think that it's something that the wider community should hear. I'm also an advocate, and I I would love to have this summary available to present to various people that were not able to be here that might find it interesting, members of various committees in different countries. Is it possible to get this presentation, your presentation, put up online?
We have 2 phones here that are digitally recording my remarks. I am going to make PDFs of my slides available for the CFIDS Association to sync to my voice, so that on their site, I hope on the IACFS site, and any other sites that would like to have it, it's made available.
Could I just say one more about potential clinical trials? We had a poster up which presented an approach that I think would be quite useful in facilitating this process and moving it forward. As we all know, we do not have an animal model for ME/CFS, but we can take peripheral blood mononuclear cells, which we have in great supply in a number of big biobanks, and we can test at least immunologic markers as potential targets in that system. And we had a poster up in which we had discovered previously and reported that interleukin 15 is decreased in ME/CFS. And we also know that it's a potent stimulus of natural killer cells, which are low. And we can show in the test tube that we can expose PBMCs to interleukin 15 and increase their activity by about 150%. So, and this type of thing could be used for a lot of immunologic markers. We could use both inhibitors of cytokines and cytokines depending on what defect we're interested in addressing. And we've had a little bit of trouble getting this concept funded, but I'm hopeful still.
No, I very much agree. Where you have a signal that says if we boosted this or if we suppressed it, we might see improved symptoms, we should do the studies in a controlled trial. Is IL-15, synthetic IL-15, available for human use?
Yes, it's Dr. Wallman at NIH discovered this drug, and this is cytokine, and he actually has clinical trials in progress using it in cancer patients.
There we are.
I have a question that, oddly enough, is along the same track as Dr. Fletcher, but unfortunately I don't have as much education and background in the area. But I have read numbers of papers where people, especially in China, have tried to construct animal models, which they invariably do by making the poor little mice or rats swing back and forth, back and forth, back and forth, about 1 million laps, and exhaust them that way. And this they call a CFS model. And it just has always occurred to me, partly looking at this, but previously having had a friend who was treated for hepatitis C with interferon, that giving the mice a good hit of interferon on a regular basis could possibly be one way to construct an animal model. And I'm really asking that question. Is that possible and would be useful?
Yeah, so we are really lucky down at our institute because we brought really grabbing teams, animal modeling people who are all into Gulf War illness and neurotoxic animal models. But neuroinflammation animal models exist, and we certainly can use them. I mean, I think one of the problems we have with animal modeling in our field is we just haven't had very many animal modelers. It's not that there aren't potentially good things, and I love your idea with interferon. And in fact, Dr. Miller at Grady and Emory did that in humans. He did a fatigue study in interferon-treated humans and then tried to figure out the correlate. So that's it's a great idea.
Yeah.
Are there any more questions? I think we're running out.
One more, because we're past time.
Is there a hand up? No. I think we ran them out.
Terrific. Ken?
Yeah.
On behalf of the IACFS-ME, I want to thank Tony for his wrap-up and concluding this meeting with an elegant presentation. On behalf of the IACFS-ME, I want to thank each and every one of you for attending our meeting and in that way supporting us and in that way demonstrating an interest in this illness. For those of you who are healthcare providers, I want to thank you for providing care for our patients, even though they may be sullied by the mainstream and not believed by many. Obviously you do. And for that, I wish to thank you not only on behalf of the organization, but also personally on behalf of being a parent of a child who has the illness. So thank you very much.
Send you PDF. Yeah, and I hope as a result of these devices, it'll be up on the web.